So we're here in Nashville at the Euromigos live meeting. We just came out of the bladder cancer session. The three of us were there. I thought you were both brilliant, by the way.
Thank you.
Yeah, I don't you do actually. Thanks for coming, number one. We talked Jonathan Rosenberg, Matt Galsky, for those who, I'm Tom Poss. Due to the introductions, that's important. We're going to talk about EV Pembro, enfortumab vedotin and pembrolizumab in cisplatin ineligible muscle-invasive bladder cancer. The trial design is a pretty simple design, although the trial wasn't that simple in its execution. The design and the results we're seeing today is cystectomy alone compared to those patients who had 3 cycles of neoadjuvant EV Pembro, cystectomy, and then 5 more cycles of EV Pembro adjuvantly, and a total of a year of pembrolizumab. There was a third arm in the study, which we're not going to talk too much about today, where single agent pembrolizumab was given. Essentially, the study was wildly positive with a path-CR rate of 57%. I said 50% would be transformative. It's well above that. It showed an EFS hazard ratio of 0.40, which we've never seen in this setting before, and OS hazard ratios of 0.5. Now, there have not been that many trials in this environment. The control arm, did poorly. The patients progressed pretty quickly. The safety was in line with expectations. There's no new safety signal with the drug. And so this appears transformative. Jonathan, you did the discussion at ESMO. What was your immediate reaction when you were sent the slides and you saw them for the first time?
I was obviously incredibly impressed and very excited to see the data. Really takes us to a new level in the perioperative therapy for muscle-invasive bladder cancer, and really allows us to think about now treating all these people who formerly never got any systemic therapy prior to radical surgery. And so really hoping to see regulatory approval over the next, hopefully within 6 months in the US at least, and then the results of the EV304 looking at the cisplatin eligible population, which is might have slightly different results.
So in that study, it's a similar number of cycles, 9 cycles with a cystectomy after 4, and that is versus GemCarbo. And that's a study which, the B15 study, which we're really excited about. But until that happens, does this apply in that cisplatin ineligible population for you? Cisplatin eligible population for you, or is this exclusive, associated with just the population in which it was tested?
I think the patients who really are refusing to get cisplatin-based chemotherapy, it's reasonable to consider this. It's clearly highly active systemic therapy. Do we know it's better than chemotherapy in the perioperative setting yet? No. Do I think it probably will be better? Yes. And that's about where we are. And so, if it's a discussion of EV Pembro or they won't have any systemic therapy, then I will, I would talk to the patient about what we know. I hope it's not going to be that long before we see data. We'll see.
We hope so. Matt, what was your initial reaction, and what was the highlight or of the discussion that we just had in our live session a few seconds ago?
I think the overall impression of the data across the individuals on the panel was incredibly consistent, which we don't always see. I mean, there's always some nuances of trial design that we pick apart, and some people like it and some people don't like it. But this was a pretty clean study. And aside from your points about the trial design changing a little bit midway, and we haven't seen Pembro alone, et cetera, overall, the results are quite impressive.
Let's just go through 4 issues on this slide here. You can see 4 issues maybe that we can discuss. We'll go through them in a second. The first is, did the study arm perform worse than we expect? The second is around what would single agent Pembro have done? Can we predict what that result might have been look like? The third was, does it apply in the cisplatin eligible space? And then the last question, do you need to give all 9 cycles of EV Pembro? So Jonathan, let's start with you. In that review you first saw, the Pembro arm wasn't presented. Were you hoping it would? And what results do you think it would have shown? Do you think it would have been close to EV Pembro or miles behind?
I think it would have been miles behind. It still might be positive yet,
Right.
But in comparison to, we know that single agent checkpoint inhibitors are inferior to other other combination of systemic therapy that we've seen both with chemotherapy and clearly with enfortumab and pembrolizumab. And so, I'm not expecting to see dramatic benefit. The adjuvant pembrolizumab study showed an impressive DFS advantage, but there's no OS advantage to adjuvant pembrolizumab. And so I'm worried that we might see some modest improvements. This control arm did about what I might expect, although we never really had a good study telling us what the outcomes were after surgery from cisplatin ineligible patients. All the data has been for metastatic disease. And so we know that this is a sick patient population. This trial shows that these patients really need systemic therapy.
Matt, I want you specifically to talk about that conversation that we had in the room, which is a change in mindset or around these patients in the control arm who are suddenly, half of them are progressing quite quickly. These patients need systemic therapy, not having their bladder removed. And does this now become, instead of a surgically orientated disease, does it become a systemic therapy orientated disease with perhaps not everyone getting to surgery?
I mean, I think that's always been the case. It's just that we haven't had either effective enough systemic therapy or generalizable enough systemic therapy to make that argument. I say it's always been the case because if you look at patients with clinically localized solid tumors treated with surgery, all comers, the risk of metastatic recurrence for clinically localized muscle-invasive bladder cancer is probably as high or higher than any other solid tumor that surgery is done for, 50% or more.
Yeah. I feel the same way. I mean, the way I look at it is we've been talking about, path CR with therapy and talking about, that and chemotherapy being the icing on the cake and you've got to get a good operation. I look at this curve and say, most of these patients have got micrometastatic disease, MRD already, and doing surgery on them is the wrong thing to do because those patients, by the time they've recovered from their operation, they've had 8 to 6 months down the line, we know when we have visible metastatic disease that immune checkpoint inhibition is not as active as we would like it to be. And actually giving these treatments, particularly EV-pembro up front, but we're going to talk about cisplatin in a second with durvalumab, early immune therapy, I think it's a change in concept. And then, people talk to me about the purpose of PathCR with neoadjuvant chemotherapy and with this treatment. I think all that's really doing is it's a surrogate of what's going on in the micrometastatic disease. It doesn't matter. If you're going to cut the bladder out anyway, it doesn't matter if you've got PathCR or not because it's in the pot and it's gone away. The issue is that a surrogate for what's going on in the micrometastatic disease and can we achieve CR and cure there? And it looks like EV-pembro is doing that effectively. The challenge with radiation therapy for these patients that have the same pattern of disease, because we're giving radiation therapy to those patients who are least well, is the majority of them will also have advanced disease. And local radiation therapy, irrespective of whether you achieve CR, is doing nothing for that spreading metastatic disease. And for me, that's a different way of me looking at this. And that's why I think these results are so transformative. Matt, I want to push you a bit, if I may, on this cisplatin eligible, because you are Matt Galsky, and it is the Galsky criteria. Are they now essentially dead? Or do we need to wait for the randomized trial of EV-pembro versus GemCis in this setting?
I mean, I hope we won't have to wait that long. These trials were initiated around the same time. Actually, one of them was initiated later than the other, but only slightly. And so hopefully we won't have to wait a long time for that answer because we want to make decisions based on phase 3 data, not on speculation. But to your point about these arbitrary clinical criteria to define a patient population who is at particularly high risk for toxicity with a specific treatment, yes, I think they're dead and they should be dead. We need to move on to better treatments and better questions.
Fabulous. Well, it was a good ESMO for bladder cancer, 3 plenary sessions. This was the second plenary session. And in this, you can see a randomized phase 3 study looking at circulating tumor DNA. Now, I'm not going to talk too much. The design is here. Essentially, those patients in the adjuvant setting, none of these had neoadjuvant immune therapy. Some had chemotherapy, but none had neoadjuvant immune therapy. And patients were stratified using ctDNA. And those ctDNA patients who were positive or became positive were randomized to atezolizumab and placebo. And then there was a remaining population which continued to be negative for that year, and they went on to a surveillance program. 250 patients were randomized, 370 patients were negative and remained negative. On the curve, those patients who were negative, remained negative, had an excellent outcome. You can see here 97% overall survival. There's some censoring on that curve. And then, of course, those positive patients, if you treat those MRD patients early, then suddenly, for the first time, you've got a positive study with OS with atezolizumab. So this is selecting the right people. This was based off retrospective data from Vigor 010, but recently, Matt, your trial, your adjuvant nivolumab trial, showed a similar thing. We talked in the room about, in view of the conversation we just had, while this is a huge undertaking and a massive effort, how this actually changes our thinking or changes our practice today. And Jonathan, you were, I think you were very fair and balanced, and your feeling was it wasn't changing things that much because things have moved on.
Right. I think the prevalence of ctDNA testing in the post-op setting has gotten a lot higher based on the Vigor 10 data, which showed in a retrospective fashion we'd find something like this. I think the therapy is what is like 2021 treatment as opposed to 2025 treatment. And so it's less important about the treatment as it is about the test and the fact that we can identify these folks early and intervene upon them in a meaningful way. And now we have better tools in our armamentarium to treat patients. And so perhaps, we'll get even better results than we might see here. I think some of the unanswered questions are, is it just the same to treat them at relapse as it is to treat them upfront? I don't know that we've answered that completely. And so here, I think there's still more data to be given. And I think we'll see what the extended follow-up shows. But, how this fits into an EV Pembro world remains to be seen.
Matt, one of the key questions that I get asked, there's a Volga trial kicking around. In the Volga trial, only 3 cycles of neoadjuvant Pembro, neoadjuvant durvalumab with EV are given. There's no adjuvant period of EV. So very similar to the trial we saw, the cisplatin ineligible study, but it's not 9 cycles, it's only 3 cycles. That may help answer the question around the number of EV cycles are given. Do we need the adjuvant period? What's your current take on that adjuvant period? How important is it? Are you always going to recommend the adjuvant period of EV for your patients, providing they're not having too bad of side effects? And are there other trials or other studies with circulating tumor DNA that can help us tell whether you need that adjuvant period?
I don't know how much EV is enough in the perioperative setting. I don't know if 3 is enough, but 9 might be too many. And so ultimately we need to answer that question. And I think Volga is going to help with a piece to that puzzle. All patients are not going to get the adjuvant portion. And like all treatment decisions that we make in medicine, it's going to be based on their benefit versus their risk. And so if they have a PAT CR and they have grade 1 bordering to neuropathy and they're a professional pianist, then they're not getting the adjuvant portion, right? And other patients are going to push for it. So we will need to individualize those treatment decisions. The modern study, which is a study assessing the role of adjuvant immune checkpoint blockade, that ctDNA guided, will in part help address this question. There's going to be some heterogeneity there because it's become a very pragmatic study allowing neoadjuvant EV Pembro to get onto that study. But if you have undetectable ctDNA after EV Pembro, then you're eligible, and that might help define whether or not you need immediate adjuvant immune checkpoint blockade or whether or not you could be monitored like you did in Vigor 11.
We're wrapping this up. We're going to end with just the future, what you'd like to see next. I'm going to start, if I may, and I'm going to say I'd like us to stop doing cystectomies on those PATH CR patients. So I'd like to look for clinical CR. I would like to do big, robust trials. I know you've got a modest-sized single arm already in this setting, Matt, where we're not doing the surgery and seeing if we can keep patients in CR, but also importantly without metastatic disease, without doing cystectomy. So that's where I am. Jonathan, build on that for me.
I mean, I think one of the questions is have we achieved the pinnacle of systemic therapy? And we may have, but I hope we haven't. And there's some very exciting new agents that are being tested in the advanced disease setting in smaller trials, and they need to prove themselves a bit more, but perhaps we can get to a situation where instead of 57% path CR rates, will be in the 75 to 80% range. And in that scenario, your trial becomes really easy to do, as opposed to controversial with certain quarters. So I'm looking for better drugs, because even this advance is not enough.
Matt, round this up for me. Say something brilliant about what you want to do next.
So I think, to your point, we need to move on from one-size-fits-all approaches to response-guided approaches. And we've been enamored with pretreatment biomarkers, but that's been a hard nut to crack. And we leave all this information on the table about what's happening in an individual patient in terms of their response to therapy and how that might allow us to make informed decisions about what to do next. We're ready to do that. We just need to do the studies.
Fabulous. Thank you very much.